Good afternoon, good morning to all of us, depending on the zones we are coming from. My name is Reverend Jane Nganga. I work for INERENA, and I'm glad to be hosting you today through this session, and we are glad that you are able to join us. So the title of our session this day is the role of faith communities in supporting programs for children and adolescents living with and affected by HIV, which is a qualitative analysis of the promising interventions in sub-Saharan Africa. And as we all know, that the needs of adolescents living with and affected by HIV, especially in our region, the sub-Saharan Africa, have been inadequately addressed. And at the moment, through the data coming in 2020, we have only about 51% of children between the ages of 0 to 14 years who are receiving ART. And this is a huge challenge that we need to ensure that we close this gap. But on the other hand, we've had faith communities responding to this issue and trying to bring about change. So faith communities have been supporting the response to meet the unmet needs of adolescents and young people living with and affected by HIV over the years. But the challenge has been that although a lot of innovation is coming through, these interventions have not been documented, and there lies a huge challenge. And there has been an effort to ensure that this happens. And there has been, during 2020 and 2021, a UNAIDS-PEPFAR initiative that took place, and there was a deliberate effort to document and really to show what is happening. And a qualitative study was done, which identified at least 42 interventions in areas of programming that are being implemented by faith communities, which can be termed as promising practices. And as a result of this documentation, we've been able to at least have a few of these interventions to share today. And these are cutting across the 4 areas where faith leaders have huge assets. One of the areas is in service delivery. The other one is in community outreach, the use of places of worship to create demand for HIV-related services, and also advocacy, which has also been done quite a bit by faith leaders. And therefore, today we do have speakers who will be speaking through the 4 faith community assets and really bringing out some of the key lessons and some of the key promising practices that are happening within our faith communities. Gipster Makangila, and he will be speaking from a perspective of community outreach by faith community groups who have been engaged in the community outreaches. And this is a case which is coming to us from Zambia. Muka Chibuka MacLeod will be speaking on how we can use places of worship to create demand for HIV services and expanding integrated health service delivery through health posts within places of worship. Again, a case of Zambia. And our last speaker will be Nkatha Njero, who will be speaking about how advocacy by religious leaders and faith-based organizations have led to increased pediatric advocacy through use of champions. And Nkatha is from Kenya and will be presenting a case from Kenya. So we welcome you to listen more from these speakers and also to engage and ask questions. And towards the end of the session, we'll have a question and answer session so that we can learn more and contribute more. It's my pleasure now to invite Gipster Makangila from Zambia. Welcome, Gipster, to bring your presentation.
Thank you very much for this opportunity to come and share what we are doing at Sake of Hope in Zambia. My name is Gipster Makangila. I'm the Executive Director for Sake of Hope Zambia. We're engaged in providing services to HIV, in HIV sector and other areas where pandemics may arise. And so I'll lead you in the next few minutes in what we have done in regards to the role of faith communities in supporting programs for children and adolescents living with HIV and affected by HIV. Circle of Hope is a faith-based organization that has been operating in Zambia since the year 2005, and we have since grown and having in excess of 29,000 citizens in the city of Lusaka, Zambia, currently receiving art. Our strategy has been threefold. Number one, in order for us to be effective in reaching out to children and adolescents, and indeed men, we've been able to decentralize service delivery to the community level. And we have done this by establishing faith-engaged community posts in markets, bus stops, busy residential settings, and churches. And secondly, we've also been able to identify and segment and map the faith community surrounding all those community posts within a radius of 2 to 3 kilometers in order for us to foster and liberate relationships that exist in these communities. These communities don't exist in a vacuum. There are very important relationships that exist. And so one such relationship is the faith community. How do they interact and relate with the healthcare providers? And so we use the community posts located in these settings I've mentioned as a rallying point in which everything converges to do with health and faith. And lastly, but not least, in terms of the strategy, we also collaborate with community influencers who may be market leaders, civic leaders, political leaders, and indeed the faith community, and use them in the planning of the community posts in terms of setting it up, planning the programming, planning the execution. We get a lot of feedback and review and assess performances together. Let me quickly zero in on the key strategies that we've used to bring on board children and adolescents. Number one, we have utilized the prevention of mother-to-child transmission platforms where we gather women at faith gatherings, in churches and in communities, and educate them in how important it is to get their babies and themselves tested if they're pregnant. Number two, we've been using index testing. This is a mechanism in which any person who tests positive, we discuss with them, we counsel them for them to identify with us persons connected to them sexually, whom we call contacts, and also identify any biological children below the age of 19 connected to them. Number three, we also utilize immunization days. These are run by the Ministry of Health across the country. So during those immunization days, we actually take time to request mothers to bring their children to these community posts. And as the children come, we take advantage to sensitize the mothers and indeed, where necessary, test the mothers and the children together. Number four, we also use a strategy working with several partners we call Know Your Child Status. And these are for children who may have been missed out during the PMTCT, and mothers are encouraged to bring all their children for testing, and elicitation is conducted upon every visit. Within the faith community, we've utilized a very important segment in those settings. These are the youth meetings that may happen on Saturdays or Sundays, where children and the youth gather together, and through their life coaches, we disseminate messages of hope, focusing on the need for them to test, to stay safe in terms of prevention, and also provide them with self-test kits if the youth feel that they've been exposed to HIV. Last but not least, we've also embarked upon a very important tool we call Coaching Boys into Men. This is where we take children between the ages of 6 up to 18, and we use the faith leaders and the life coaches who are from the community to train them on life skills, and issues of violence against women, gender violence are taught, and we also teach them about HIV in terms of prevention and adherence to treatment for those who may be on treatment. Currently, we're just about to graduate 840 children trained in the last 13 weeks. And so we've seen a lot of impact in terms of children and adolescents being linked to treatment and being kept on treatment. A bit of statistics, we have a typical performance in our programs in regard to children and adolescents who have been linked to treatment from October 2020 to July 2021. You've seen the trend, very positive trend, where we've seen and identified a lot of kids and linked them to treatment. I'll just highlight our positivity yield has been about 6%, and we have a linkage in most cases of 100%. And so we've seen through this model a very powerful identification of the children. In our model, we want to attempt to find the missing children and find the missing men. The next slide compares a non-faith-based facility working in the same environment with our community posts and the sake of hope. And the difference in performance, as you could see, is very clear in terms of the efficacy to find and link children and adolescents to treatment. In terms of treatment, we, like I said earlier, we've currently enrolled recently almost 850 children and adolescents who are accessing art services in the faith community. We've also embarked on giving the children and adolescent quality focused services such as booking appointments, and also we've set up specific days in which children are given the highest attention, and so they feel very important and cared for through youth-friendly services. Further, the providers who are working with these children are also constantly discussing the drug formulation with the children in order to enhance adherence and compliance. As you know, children are sometimes prone to drug fatigue, and so through counseling and certain formulations, we're able to sustain them on treatment and encourage them to continue being on treatment. And those kids and adolescents who have been identified positive are immediately initiated on ART and linked to peers who encourage them on a day-to-day basis. We also have introduced multi-month dispensation for children so that we don't see them as often as they can. The next slide illustrates our performance comparison between a faith-based facility, same number of facilities and same environment, with a non-faith facility. So the graph on top is for a faith-based facility, and this is in reference to the number of children found in this period compared to the non-faith facility. As you could see, the difference is immense. And this is as a direct result of engaging the faith community. The next slide illustrates again the performance of children and adolescents in as far as linking them to HIV between the period October 2020 to July 2021. In terms of retention, through this model also, we've seen a slightly higher retention trend among the adolescent subgroups who are subject to adherence fatigue. And so we've done this through interactive sessions among adolescents receiving ART, youth-friendly services that are very friendly, and using younger adults to be the front-line counselors, providing the support to these fellow youths. So that has been phenomenal. Under retention as well, we've also used the faith communities and faith leaders to continuously carry out some home visits because of the trust they enjoy and the access to households which they enjoy in communities, and also the intricate knowledge which they have. We have leveraged that in very important attribute they have, that is the faith community, to actually help us manage those children, manage those adolescents and guardians who are having difficulty to stay on treatment or to accept the status of their children. The next slide illustrates the faith community contribution in terms of children and adolescents and how we monitor them. So meaning that we're able to retain most of the children and adolescents who are on treatment. The loss through deaths and the loss through transout is very, very minimal because of the support of the faith community. And what are some of the issues? The issues really that we've encountered is that sometimes kids tend to have very high viral loads issues, and so we've been able to now monitor those viral loads and ensure that they're brought into suppression. What are the major challenges we've experienced? in the last 1 year in regard to children and adolescents. Basically, it's the COVID-19 restrictions and the drug fatigue. So thank you very much. This is the presentation from Sake of Hope. Thank you.
Good morning, good afternoon. I'm Dr. Susan Hillis from the CDC, and I will be speaking this morning for my colleague, Dr. Mukuch Kuba from USAID Discover Health about holistic versus routine care for HIV in young men. And I'll be talking about the comparative performance of these two models during COVID-19. This work all started because of a mandate that JSI had to take HIV and other health services to underserved communities, particularly informal settlements, as close to home as possible. And what the challenge was is that these large high-density informal settlements often lack accessible healthcare services, particularly HIV services that would facilitate treatment and continuity in treatment. The challenge was that in these informal settlements, there really are no obvious structures that could be used to help provide these services close to home. The solution we happened upon, or Muka and her colleagues happened upon, because of a bathroom break at the United Church of Christ in Zambia's St. Luke's Parish in the Kuku compound, when she ended up talking with the pastor about what they were looking for, and the pastor asked her, why don't you just start one of your clinics here? So long story short, here you see the church in the background with the clinics, the mobile clinics in trailers in the foreground. And these co-locations of church and clinics really leverage the reach and influence of the faith communities by locating the health posts right on the church property. There was full faith partner engagement from the very beginning. 8 faith community partners engaged in what expanded to become 29 health posts, and they received technical support to strengthen their systems and really equip them to manage health programs and donor funds, particularly implementing targeted HIV testing and services and linkage to antiretroviral therapy and other HIV preventative services. The quality and dignity was always emphasized because the clients had access to client-centered care very close to where they worked and worshiped. And there was a special focus of this work on gaps in both pediatric and young male treatment and case finding for the healthy. What we find here and what we're showing is the FBO, or faith-based organization facility footprint, out of all the USAID Discover Health clinics was 8%. But what you also see is there was a disproportionate positive contribution to helping persons infected with HIV continue in treatment, because even though they had only 8% of the clinical share, they were providing 12% of the continuation in treatment for those infected with HIV. Now we even have the Ministry of Health wanting to collaborate with and continue to extend these models. What we find is that these faith-based clinics that were co-located were particularly effective in reaching the missing men. They strengthened case management by providing additional phone data and talk time to case managers. They strengthened index case testing and scale up by placing client preferences at the very center of the process, and continued to be effective during the COVID lockdowns because the churches were allowed to continue operating if they could do so safely. And they provided client-centered HTS and ART initiation services at the clinic or community at the preference of the client, including 6-month, multi-month dispensing. Here, I want to really call your attention to the first 2 bar graphs. And again, you see that the yield of HIV testing was 11% in the faith community sites, significantly more than the 7% in the non-community sites. And you also see here that the indexing yield was remarkable, 50% in the HIV, in the faith-based sites versus 36% in the non-faith community sites. And this is particularly impressive when we think that these are primarily asymptomatic young male clients they're serving. And then if we proceed to look on at the preventive services, we find this same striking pattern. Again, remember we had talked about these faith community sites only make up 8% of the total footprint of these sites, the clinical sites that USAID Discover Health supports, but they provided 11% of the new PrEP initiations, and they provided 13% of the new male circumcisions among 15 to 34-year-olds that they served. They found that one of the reasons for their success is that they intentionally addressed two of the major barriers among young, healthy men for HIV testing and seeking services, and those are shown here in year 1 and 2, that fear of apprehension about a positive diagnosis and living with HIV, and also problems that we ourselves have created in health systems by causing men to feel shut out of them. So in summary, for these faith community health posts that are co-located at churches or mosques, what is it that made them work so well in finding and retaining men? First, they had health system fixes because they use Zambia data to make the health system more accessible to men. Next, they had scale up of proven interventions, particularly targeted testing and indexing led to increased efficiency of case finding. Third, they had client-centered care by taking these services to where the client is and tailoring them to the client's needs. Even in situations where the men were not active participants in the church, where there was a co-location, typically the men would have a wife or a mother or a sister or an aunt, someone who was in the church who could help link them to care close to home or in the community, even surrounding the church and in the informal compound. The fourth thing is they maximize opportunities for HIV epidemic control by linking the negative males to PrEP and voluntary male medical circumcision where appropriate, and other HIV prevention interventions. And finally, this last one in focus group interviews was strategically important and is something that all of the faith-based facilities and organizations can offer. They incorporated spiritual and health mentorship for the young men, addressing the needs of the whole person holistically and not just looking at them as having their identity based in their HIV, but their identity based in their worth and value as individuals, addressing their fears in their context, working in partnership with a trusted faith vehicle. Thank you very much.
It is my pleasure to bring Nkatha Njero to make her presentation. Welcome, Nkatha, to give your presentation.
It's a pleasure being here today and talking about the advocacy by religious leaders and faith-based organizations, specifically for Faith Pediatric Champion in Kenya. I work for the Africa Christian Health Association platform. ACHAP is an organization that nationally has members that are organized as mission health facilities and programs through their Christian health associations. We are in 32 countries with representation by 43 members. We work to facilitate capacity and partnership building, as well as networking and joint advocacy by our members, and our secretariat is in Nairobi. For this specific intervention that I'm going to talk about, we've focused on identification of children that needed to be tested for HIV. Of course, testing within ethical considerations, ensuring that they had access to HIV care and treatment and psychosocial support without any stigma, and also monitoring of their adherence. The approach focused on identification of faith leaders in the area that we were implementing in, also involving these faith leaders from both women groups, men groups, and youth leaders, not just working with priests and pastors and sheikhs. We also work to establish a network in the community of these leaders, and we link them with health facilities within their area of operation. We also built their capacity on basic HIV and AIDS information. What was their role in this intervention? The first thing they did when they identified the children as champions, they made referrals to health facilities. They also would do home visits in the course of their normal visitations with their congregations. They also had the opportunity to address religious gatherings, specifically on matters pediatric HIV. They also had the opportunity to support the development of peer groups of the children and caregivers that were identified as HIV positive. This intervention also worked to provide supporting tools for the religious leaders. One of the tools that is also available on our website is the HIV counseling guide for religious leaders that they can use to counsel members of their congregation or people that need HIV counseling. We also have the guide for religious leaders on children and HIV that provides them information on children and HIV. Both of these have citations from the Quran and the Bible. They were developed through the collaborative effort of theologians, religious leaders, clinicians, as well as caregivers and people living with HIV. They provide sermons and quotas for the religious leaders that they can use with their congregations. Through this intervention, these are some of the results that we were able to get. Like you will see, a lot of the referrals were actually made by religious leaders and youth leaders who are actually youth leaders from the congregation. So youth leaders in the churches or the mosque, compared to the community health workers who are the traditional means of engagement for communities. So these were our results. What do we consider to have been the impact of why religious leaders? As you know, many of our mission centers have a school, a church, and a hospital. And this therefore gives religious leaders access to 3 safe spaces because they are able to interact with the school, with the church or the mosque, as well as the hospital or whatever health facility with confidence. They have a captive audience many of the times. That means weekly and also regularly and on special occasions. They also have religious leaders as trusted by their followers. They provide continuity and sustainability because unlike projects, they have access to communities even when there is no funding. They are a first point of contact for information and are a resource to communities, and they also have influence and are gatekeepers. People will go to their faith leaders with questions about issues and believe whatever they have to say. Thank you for listening to me.
Wow, what a great session to have had the speakers really bring to perspective some of the key assets that we have in the faith communities. And indeed, that was quite in-depth, and we have had a lot of understanding of the work that the faith communities are doing. And at this point, we want to have a few minutes of interactions where we will have a question and answer session so that we can be able to understand a bit more how some of this work is being done. And it's my pleasure now to bring Dr. Stuart King, who is part of the Faith Community Initiative, to take us through that session. Welcome, Dr. Stuart.
Gibster, thanks very much for your presentation, which was very interesting. Please will you explain the importance of the faith community engagement in the community post-intervention? How has the faith dimension made a difference?
Thank you very much, Stuart, and thank you, Reverend Jane, for the very important questions in regard to the community post and our approach in the faith community engagement in service delivery. We would like to mention that the faith community brings on board certain inherent attributes, such as the trust factor, and also the access to households. And further, they seem to have intricate knowledge about most issues happening in communities. They are normally the first to know about issues, social issues, and so on. And therefore, by utilizing them in HIV service delivery, we are actually accelerating this impact of finding men, finding children, and finding adolescents because of the trust that they enjoy. And so they also bring on board a very important element we call empathy and compassion and a sense of responsibility and a mandate that is higher than the normal vocational mandate. And so it's important to recognize these elements that this community brings to the fight against HIV and indeed any other pandemic fight that may be existing in society. So that's the first answer I would like to give you, that they bring in this unique insight into the issues happening in the community. They have access to households and they have intricate knowledge of what's happening and who's who in any given community.
Are there one or two other more specific elements that you think that having the fact that these people are people of faith, that actually means that there is, I mean, you talked about the compassion, for example, that they that someone who they meet at a community post somehow is able to relate to them better. I mean, I think that's what we would, an example of that would be very helpful.
Thank you, Stuart. I think I could add a couple. Yes, so as I was saying in regards to the importance of the faith community, one of the things we've done to work with this community is to actually open community posts in the church grounds. And so we have seen that the acceptability of the membership of various churches is higher if we have this community post located in the church grounds. Secondly, we also have trained and oriented these faith champions who are the clergy in disseminating the messages of hope. And so every Sunday after a sermon or a service, they'll spend a minute or two to talk about the need to test, and the need to adhere to treatment, and the need to stay on treatment, and also emphasize the balance between faith and treatment. So the faith community has been able to help us demystify and handle and tackle some of the myths concerning treatment for those who are given to believing faith healing only. So this community, as I said, has been available, and also they are the ones who provide what we call enhanced counseling for those persons who are defaulting in treatment because of faith healing or because of the loss of a loved one. So they take advantage of forums such as funerals to disseminate the same message, marriage settings, and any other grouping settings in churches, such as the women's ministry, the men's ministry, and any religious gathering. They throw in a message of hope to encourage citizens, parishioners, congregants to actually test, stay on treatment, and still combine faith and treatment.
What advice would you give to someone who's thinking of scaling up this intervention of community posts elsewhere?
What advice would give to organizations or countries or individuals wanting to replicate the community post model? Yes, this is the way to go. My first advice is that they must establish very important relationships in the community and leverage those relationships with two important players in each community, especially in Africa. Community number one are the faith communities themselves. They identified the community influencers. That includes the clergy, the priests, the pastors, the imams, and any other full-time vocational citizens that are practicing faith and religion in some setting, such as a church or a mosque. Now, this is important because they already command a reasonable constituency. So for the community post to work, it thrives on the relationships that have been established in these communities. On top of that, these communities are going to second or volunteer their members who are faith engaged to work in the community post that is health-based. So the community posts are providing the health, but this service is being provided for people who are inspired, compassionate, and also passionate about what they are doing. And so that's the advice. Don't go it alone. Encourage and involve from the outset the faith community existing in the community you want to plan to open a community post.
Why has the community post approach been so successful?
And like you heard in the presentation earlier, we in a period of 2 years, we moved from a TX car or having 3,500 citizens in one locality on treatment. In 2 years, we've been able to add 29,000. This is the same number of staff, the same number of districts, and so the results of the community posts have been phenomenal. This has been really done in partnership with the faith community. And we added a little dimension of what we call the core value. This is a core value that all the members of the community post and the faith community have embraced. And this core value is based on an acronym we call the RESIC, which stands for R, responsibility, E, empathy, C, compassion, I, integrity, P, passion, and E, ethics. So that core value rhymes and resonates very well with the faith community as a whole, wherever they may be found. Thank you.
Well, thanks very much, Nkata. That was a really interesting presentation. I'd like to just tease out a few points by asking some questions. Firstly, why have faith leaders been able to play such a key role on paediatric HIV as paediatric champions? Secondly, what training did faith leaders need to receive to be effective paediatric champions? And third, what advice would you give to someone thinking of trying to establish faith paediatric champions to be successful elsewhere? Thank you.
Thanks, Stuart. I think to start with on why I think that the faith leaders have been able to play such a role and been successful. We have faith leaders in communities as gatekeepers. They also are present in communities without regard to, like I said during my presentation, availability of resources or not. So they live in the communities and are part of these communities. So their work is actually just part of what they do. They are not doing it as part of a project or towards just one specific agenda. I think also they have been successful because of the fact that they understand their communities. They know their communities, they understand them, and therefore they're able to interact with them in ways that other people might not be able to. So having said that, then, what kind of training do they need to be able to do this well? For this project specifically, one of the things that we realized was that communities are as informed as their leaders. And for us, the religious leaders, therefore we needed to consider them first as community leaders and do the same kind of training that you would for any community leader in terms of HIV information. So they would ask us the same questions that any other community leader would ask. For example, can I get HIV this way, or can I not get HIV this way? So you have to assume that they don't know and start from the basics of HIV, build the information, ensure that they understand, also make sure that they feel supported towards this understanding, not consider them as people who should be able to have this information and know. So we provided them basic information on HIV, specific information on HIV in children, as well as information on counseling in HIV, because people come to them when they test HIV positive. So we needed to make sure that they're ready to receive their congregants in this regard. And then lastly, on the last question about what advice I have for anybody who would like to take up this in any scale, I think first of all is for us, we are a faith-based Christian organization, but communities do not have only Christians. So when we did this, we considered the community as a whole. So you have to go through the community and find out what religions do the communities subscribe to. When you have mapped that, then bring together all the religious leaders from the different congregations and try to bring them together. Start from a point of what do they know and what don't they know. For example, in our case, we had issues at the beginning with certain faiths who completely did not want to hear about HIV, including their religious leaders. But when we brought them together and started from their point of information or understanding, then we were able to bring everybody to the same page. So I think the first thing is to map your community to be able to start. Thank you.
Thank you so much, Dr. Stewart, for such a great question and answer session. Indeed, we have been able to delve deeper into the issues and specifically also on some of the examples of the work that is going on. And I thank you too to our participants for listening in, and to the presenters for the wonderful responses that you have given. And as we come to the close of this session, we have indeed seen the distinctive contributions that faith communities are making in the pediatric and adolescent HIV response. And we've seen also that they are doing it using distinctive assets. And I think this is work that requires further support so that it can be scaled up even further. First, we've seen that they're using the service delivery through faith-inspired health service provider as an asset. And through this, faith communities have been able to support pediatric testing, ALT treatment for adolescents and young people, and also for children. They are supporting care and support using integrated and holistic family-centered approaches. And this is going a long way in ensuring that adolescents and young people and our children are receiving HIV services. Secondly, we have seen the other asset around community outreach through faith community groups and volunteers. The contribution is bringing on the table. And as a result of these outreaches, there has been support for mothers and also the elimination of mother-to-child transmission. There is also the scaling up of involvement of men in family-based testing. There is the support in terms of scaling up treatment, care, and support for adolescents, young people, as well as children. The third asset that we have looked into is using places of worship to create demand for HIV services. And really, we've seen that faith communities are at the center of community engagement. And as a result of this, we have seen there's a lot of support for HIV testing that is coming through, including the use of health kiosks. As we have heard from one of the presenters, there is increased case identification and linkages to treatment that is happening, as well as support for retention through very innovative ways like baby showers, supporting retention in care, and viral load suppression through support groups. And these are specifically support groups for children, support groups for adolescents and young people, and even mothers who are living with HIV. And the last asset that we have looked into is in the area of advocacy to address bottlenecks and government commitments to end AIDS. And we have seen how religious leaders have had personal commitments, either in testing, either in preaching sermons to tackle HIV stigma and discrimination, creating awareness around pediatric HIV/TB through training and campaigning with religious leaders and even representatives of faith communities to really ensure that there is advocacy going on pediatric HIV/TB treatment, and also diagnostics for pediatrics. And indeed, it is a lot of great work that is going on through the faith communities and through some of the assets that are within the faith communities. And it is our hope that these interventions will continue being promoted within faith communities and beyond. We also hope that we'll be able to scale up also some of these practices. And also we hope that we'll continue building bridges of collaboration with other sectors, especially within sub-Saharan Africa and Africa as a whole, so that we can continue being effective in our response. And indeed, this has been a great session, and I want to thank all of you for being part of it and for all the contribution you have made in ensuring that we have such a great session. For now, we want to stop here, and a big thank you from myself and all the presenters. Thank you.